Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus Podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. Today's episode is brought to you by Flawless Motion, and we've got some pretty exciting news. Flawless Motion is coming to the UK. We've opened a UK company and warehouse so you can order locally with fast delivery and easy returns for people living in the UK. So no more waiting for international shipping. So if you're working with athletes who need a proper shoulder support with bilateral and women's designs available, then check this out at flawlessmotion.co.uk. Right, on with the podcast. Welcome to the Glenohumeral Gurus. It's my pleasure and privilege today to talk with Jean-Sébastien and François Desmeules from Canada about the recent clinical practice guidelines they have published. So welcome to the podcast, guys. I'm excited to talk to you. We met in New Zealand recently, but ran out of time for this podcast, eh? So now you are safely back. It is snowing yet in Canada? You have
Yep.
snow? Yeah?
Yeah, yesterday we had maybe 5 centimeters.
Yeah. Okay.
Yeah, a nice winter day
So,
yesterday.
so Jean-Sébastien is in Quebec City. I'm in Montreal, so they get more snow than we do in Montreal, but
Yeah.
a bit of snow in Montreal too. So
Bit of
it's cold.
snow as well. Yeah, well, we're heading into our New Zealand summer and getting ready for Christmas. So this is our Christmas
Yeah.
episode. So if I forget in my excitement, Merry Christmas. I hope you guys have a wonderful Christmas.
Thank you.
Do you want
Merry
to
Christmas to you.
share? Thank you. Thank you. Do you want to share with the audience your physio journeys, how you got to be doing? Wait, Francois, shall we start with you? How do you got to be doing what you're doing now, and what is it that you're doing now? Tell us your journey.
Well, so yes, I started my journey as a clinical physiotherapist, actually working with Jean-Sébastien in the same hospital. We were together at the beginning of our careers as clinicians, and we were working in a outpatient hospital clinic where we would be seeing a lot of shoulder cases actually, and we worked with some very highly skilled and competent physiotherapists in shoulder pain. So I guess that's where we got our interest into looking at shoulder pain. And then, a few years after that, we did masters, PhDs, and postdocs, and ended up being recruited in some in University of Montreal for myself and Laval University for Jean-Sébastien, and we got to be appointed as new professor, and we eventually got some funding to do a bit of research in terms of coming up with knowledge synthesis on shoulder pain and rotator cuff related disorder, including rotator cuff tendinopathy that we're going to be talking today about.
Yeah.
So yeah, that's pretty much it, I guess. So University of Montreal, full professor right now. Also doing a bit of clinic still, seeing MSK cases and private in a private practice, and
Mhm.
integrating a new role in advanced practice in a shoulder clinic with surgeons at the moment right now. So yeah.
Yeah. So because you've also done a lot of work, haven't you, on advanced practice and how that rolls out.
Yeah. So my two areas of research are related to shoulder, and I do a lot of stuff with Jean-Sébastien because we love working with each other, and and we do, and we actually enjoyed having a pint too together, and we so I do a bit of work on shoulder with him, and he does a bit of work with me on advanced practice stuff too. So yeah, my two main areas are related to that.
Yeah. Jean-Sébastien, is there anything you want to add to?
One I had, yeah, yeah. It all started in '97. So I've been working for many years. I started as a clinician for 10 years, then started my appointment at Laval University. doing research with François and with other great colleagues.
Yeah.
And a lot of shoulder work. And a lot of ideas come from having a pint and discussing what we should do next. And then we start writing the day after a new grant and try to get the money.
I think that's how that happens, though, isn't it? That's what I really enjoyed about you guys visiting was the exchange of ideas and so
Yeah.
inspirational, some of the work that you've done. And I was a little bit daunted by the 40 pages of the clinical practice guidelines. So I thought what might be nice today is to try and condense those 40 pages into something that clinicians could take and use and listen to on their way on to work. What's the purpose of these guidelines? How do they come about? You've both written a few guidelines now.
We wrote a few guidelines, but it's basically the same guidelines with different iterations. So it's all the same work we did. We started this whole journey doing the CPG, started in 2012. We were funded to do a knowledge base on the shoulder for workers, shoulder evaluation and intervention and return to work for workers with shoulder pain. Mm-hmm. So it's all started there. We started to do systematic review, meta-analysis. And then François said, we have enough data to do a CPG now because all the hard work was mainly done. So then it's a lot of steps because you have to integrate Delphi. You have to have a huge steering committee to make sure you have all the expertise that you need to make sure that you can cover all the different topics, evaluation, intervention, return to sport, return to work, everything, imaging, clinical tests. The first CPG that we published included also surgery. So we needed surgeons, we needed pharmacists. So we had a huge team. Because at the end, I think it's very relevant to have a CPG because you see what are the high evidence for the different intervention, and then you can choose what you will do with your patient based on the evidence. So I think that's the main goal to make sure that you're not using low value care and you're trying to target the intervention that have been shown to be effective. So you know that what you're giving to your patient is high value care.
Yeah. And so if we break up the CPG, then if I speak to you around the assessment of rotator cuff tendinopathy, what do you think is important that clinicians know around assessing rotator cuff tendinopathies? What should they know?
What should they know? I mean, there are so many tests. When we do our PT course at the university, we learned so many tests. These tests are interesting, but you cannot base your whole diagnostic on a single test. So their value is modest at best. So you can combine different tests, but you should question your patient. And the sad thing about this CPG is that there is no good evidence on which question you should ask. So in the CPG, it's mostly based on expert opinion. Yeah. So what we say is that you should question your patient on different element, like why you're consulting, age, gender, age dominance, what they do, what kind of work they have, what kind of sport they have. Try to see if they are a psychosocial or a contextual factor that could lead or explain like the chronicity, persistent of pain, if they had previous treatment, previous tests. So just have a whole global view of your patient. Make sure you know the patient goals also, because sometimes we may want more than the patient, or sometimes we don't. The patient has like specific requests that we don't have if we don't question them. So the subjective part of the evaluation should include what we usually include in our evaluation. And then make sure that you don't miss any red flags like we usually do in our clinic. What we put in the CPG was to look at suspicious deformity, if the patient has fever, chills, sign or symptoms suggesting cardiovascular or visceral impairment, history of suspicion of cancer. The first part is mainly for acute cases. The last part, like history of suspicion of cancer, could be with acute or chronic cases. So you should look and then determine if you have low concerns or high concerns, and then if you start your treatment, even though you may have concern related to red flags. Then you can move to special tests. Like I said, there's so many tests. Some are recommended in our CPG to rule in or rule out a rotator cuff tendinopathy. We say that the best test to rule in is the painful arc of motion. Again, I wouldn't rule in rotator cuff tendinopathy based solely on the painful arc of movement. Usually, rotator cuff tendinopathy is a diagnostic of exclusion. So you have to make sure that you exclude all the other possible shoulder disorders before moving to a rotator cuff tendinopathy. So you have to make sure that there is no capsulitis, instability, history of dislocation, things like that, osteoarthritis. And then once you clear everything in the neck region, that can bring pain, but not as often as clinicians think. But once everything is cleared, then you can start doing your special tests, like the painful arc to rule in, the test that we recommend to rule out rotator cuff tendinopathy is the Hawkins Kennedy test. But again, these tests are not perfect. So yes, you can use it, but they have to be integrated with all the information that you get during your subjective evaluation and the other tests that you've used to exclude the other disorders.
Can you just remind clinicians, because some people listening might not be particularly familiar with ruling in and ruling out, can you just remind people how they work? So the presence of a positive test versus negative test, what that means.
Yeah, so rule-in usually, like for the painful arc of movement, rule-in is if the painful arc of movement, the test is negative. So usually they have high specificity, so you can use this test to rule in. So if they, and my English is not perfect to explain this highly complex thing, but usually you use a test once it's negative, you say, okay, you can rule in if this test is François, you have a better English than mine. Can you explain the?
Wait. So I'm not sure where you were at the moment. So ruling in would be a highly, if the test is negative, which is highly sensitive, if I'm correct, then it means that if it's negative, then you can exclude the pathology. If it's rule out, it means that it's got high specificity, so that if the test is negative, you're ruling out the pathology, if I'm correct.
And so what does that mean for clinicians? Let me take that back, because if the person has a painful arc, then we can say they are likely to have, that would contribute to us if they have a painful, and if they have a negative Hawkins and Kennedy, then they are unlikely. Is that?
So you're exactly.
So that's what people need to know. Yeah. So it's just to understand, because it does get pretty cloudy in that sensitivity specificity space. But
it does.
The take-home message: if you have a positive painful arc and you have a pain as you lift your arm, typically I think about that in abduction, but scaption, you guys have a preference for what that means? Doesn't matter.
I also prefer abduction because it's easier to get symptoms in abduction, but it's been described in flexion and abduction mainly. You can also do it in scaption, but usually in studies it's either in flexion or abduction.
Yeah, right. And then
Yeah,
a negative Hawkins and Kennedy test that's passive
Yeah.
across body
yeah,
would rule out the likelihood of rotator cuff tendinopathy.
yeah.
Yeah.
I didn't want
But again, the sensitivity and specificity of these tests are not at one, so you have
yeah,
to be careful. Usually they are around 0.6, 0.7, so there's
yeah.
already a 30% chance of an error in the test.
Yeah.
So
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 in
just be careful.
combination, yeah, with these other
Yeah,
factors, and as a
yeah.
standalone, we know none of them are that great. Can you talk then? We didn't talk about this previously, but I'm interested in the broad umbrella term of cuff tendinopathy, because clinically, I think I see people who have a scapular problem that contributes to that. They have instability that contributes to that. They have loss of range of movement. It might be a
Mm.
bicep problem that clinically I might treat a little differently. What are your thoughts around this broad umbrella term versus the different subparts of it? What do you think?
What I think, I mean, it's a multifactorial disease. So there's so many reasons that you can have a rotator cuff tendinopathy. So
Mhm.
you have a name, but under that you have different disability that can lead
Yeah.
to pain. Like you said, sometimes you see people with weakness that have the same symptoms as someone who doesn't have any weakness,
Mm.
but have less flexibility. Um, you have someone with a very good glenohumeral or scapulothoracic control who has the same pain as someone who has very bad control. So yeah, it's a thing to determine that is rotator cuff tendinopathy, but then you have to find why this person has tendinopathy, why the pain is persistent, and then that's where your evaluation will be very valuable. So I mean, the test, the special orthopedic test that we just mentioned, they won't really help you to determine what you will do with your patient. It will just help you determine that yes, you may have rotator cuff tendinopathy, but then you have to look at range of motion. You have to look at strength, all the things that we usually look at
Yeah.
with our patient. We also have to look at psychosocial factors that may influence the presence of pain or the persistence of pain.
Mm. Mm.
So it's not because you found what the patient has that the rest will be easy. It
Yeah.
won't be easy. You have to find what provoke pain, and
Yeah.
that's the best part of the evaluation. It's
I
to
think
find
so,
that
but it
find
segues
yeah.
really nicely into Francois' contribution around the management of rotator cuff
Mm.
tendinopathy, because now we have this umbrella term, and in the assessment,
Yeah.
we look to see all those different factors. What should we do for these people?
Well, that's a good question. I think we've got really good recommendation for clinicians into the clinical practice guideline. And if you look at the highest level of evidence and the strongest recommendation that we have is to actually treat patient initially with exercise. So it's a grade A level recommendation for
Mhm.
reducing pain and improving disability in these patients. And so, yeah, exercise is a very broad term. So
Yeah.
exactly what should we be doing? And it comes back to what you're saying. So say if we've got these specific physical impairments, how specific should we be with our exercise?
Mm.
And I think that's fine. I think we know it, like physiotherapists are really good at picking up these physical impairments specific to having a cuff that's painful or rotator cuff tendinopathy. I think that's great. I think sometimes the profession goes overboard in terms of being so specific in terms of their treatment. I think there's a lot of data showing right now that, sometimes we don't need to be as specific related to some of the impairments. And I'm not saying that we shouldn't be looking for that as professionals, as clinicians. I think it's fine that we're doing that. I think sometimes we're sort of overcomplicated stuff. If you look at spinal pain, we've come maybe further away in terms of the evidence there that's showing that we actually don't need to be very specific for
Mm.
spinal pain. And I think for shoulder rotator cuff tendinopathy, if you look at the evidence, it's sort of going that way too. So yeah, there are physical impairments that we need to look at, and exercise is going to help produce pain, improve disability. So what sort of exercise should we be doing? But the evidence out there is still that, that we can do pretty much a lot of things in terms of exercise. It could be motor control, it could be scapular focus, it could be eccentric, it could be strengthening. And it looks like that all these things are actually improving our patient in terms of pain and disability. And there's a lot of trials out there. So you can't just say that there's sort of a gray zone still in the literature. Overall, there's a lot of programs that do work. If we, through the system, through our CPG, we did a systematic review and meta-analysis and looking, what sort of exercises could be better to treat rotator cuff tendinopathy. And we've published that in JOSPT just before publishing the CPG. And we came up with that conclusion is like a lot of exercises are good for our patient, but it looks like that motor control exercises could be a bit better overall. Not a huge impact, but in terms of reducing pain and disability in the short term, especially pain, it could be a bit better. It could get our patient a bit quicker on the way to recovery. So that could be a good thing to do. But at the same time, Jean-Sébastien and Marc-Olivier Dubé are a student of us, actually published a trial, in BGSM that showing that, different types of exercises were equally good, strengthening or motor control exercises. And they were actually not superior to just giving them general exercises and general advice and education to treat their shoulder pain, rotator cuff tendinopathy related pain. So the jury is still out there in terms of what's the best to treat our patient in terms of exercises. So there's a lot of options for clinician. I think it's fine that we talk about the fact that having a physical assessment that looks at specific impairments and try to aim to correct those impairments is fine. But I think that overall we're maybe sometimes overcomplicated things in terms of, initial treatment. If patients are not doing well and they're following initial rehabilitation, they're not faring well, they're not improving, then, there might be a different population from the overall available evidence regarding rotator cuff tendinopathy and treatment. But yeah, so I think, there's a lot of options, in terms of, types of exercises. Motor control might be a bit better, if you look at the overall evidence. And in terms of dosage, we don't know. It could be very mild in terms of dosage. It could be quite long, but there's a lot of programs out there that seem to work with these patients.
Yeah, which is good to know, really, because as a broad starting point of you educate your patient around, what the pathology is and how they might be able to start moving and to incorporate some kind of exercise. That's what clinicians should be doing as a
for sure.
line. And can you define motor control exercises? How do they different than graded? What do you mean when you say motor control? What is that?
And that's again, that's very yeah. Do you want to go, Jean-Sébastien? Yeah.
I mean, there's still different definitions of motor control exercises. Usually, you look more at the quality of movement, how people move, and you look if you change the way they move, if it changes their pain. So that's basically usually what we do with motor control exercises. With strengthening exercises, we just do the exercise with specific parameters. With motor control, usually you use a feedback to improve the quality of movement, but you also want to see an effect of the pain level during movement. And you have different parameters. Usually you try to reach like fatigue or maintain a good movement quality. So, but there are so many different ways to do, or different definition for motor control exercises. So that's what we usually use when we do studies with motor control exercises. It's really improving the quality of movement. It could be glenohumeral movements. It could be scapulothoracic movement, or both. But using feedback to just make sure that the patient are learning how to move, how to correct their movement, how to improve their shoulder control,
and change the symptoms. Usually
of course.
So yeah.
Yeah, which is incredibly empowering for people, isn't it? Because in that way you're improving their self-efficacy. They have greater belief in their ability to change their outcome.
And that might be the external factors that actually making motor control exercise maybe a bit better to treat patient with MSK pain or rotator cuff tendinopathy pain as we're talking right now. So
yeah.
Because usually you also integrate strengthening with motor control eventually. So usually with motor control, you start with very easy movements. So it's more gradual than strengthening exercises. But at a certain point, you start with the resistance, motor control with the resistance. So you combine easier exercises that you gradually increase the difficulty. And then you have the strengthening part. Because I'm not sure we really do some strengthening in physio or in rehab. I don't think we use loads high enough to really to strengthen the muscle. I think we just put resistance on the tendons, on the muscle. And I think it's enough for most of our patients, especially those around 45, 50. Youngest one, the more those who have sport-related injuries, maybe you need to do real strengthening.
Yes.
But for the older patient, I think just putting some resistance to the tendons and the muscle is enough. And this is just what they need.
Yes. And so when you were in New Zealand, Francois, we talked in detail, didn't we, about the 12-week and what happens at further down the line. And we don't necessarily need to revisit that discussion here today. But I think what is useful for people to know in that acute, that early rehab phase, the role of education and some kind of exercise to get people started. And then if they are not improving, there are a number of different options. Do you want to speak to that? What you think the overall trajectory of rehab looks like for people, and for people who are improving versus aren't improving, what the options are?
Yeah. So if you go back to the CPG, what's interesting is that, and not all CPGs have that. I think that's something that's really useful for clinicians, is that we've got decision tree that actually that sort of prioritize what intervention should be doing it first, and then the ones that should be doing following some sort of if you've got a patient that's not improving, and so on and so on. So within the decision tree, we had lots of discussion about this, and it was part of our initial CPGs, not the one published in JOSPT, but we had a Delphi study within that to decide when should we change something in our initial treatment with the patient. That would include, as we've talked, exercise, education. We haven't talked about the other modalities. The other one that could be there is manual therapy, because we know that it might help in terms of short-term pain relief, manual therapy. But we've said in the guideline that, like, if your patient is not improving significantly within 12 weeks, then you should be reassessing the patient, and then you should be deciding on offering something else to your patient. And then related to that, you need to reassess the patient. You might need to send the patient for imaging. And if you're still having a diagnosis that's related to a rotator cuff tendinopathy, then maybe you should be offering him that person something else. It could be injections, it could be a referral to an MSK specialist, medical specialist, to reassess and make sure that we're not missing on something. But so initial imaging is not necessarily it's not necessary in most cases of patients showing up to physiotherapy for initial treatment if there's no trauma. But if the patient is not improving within 12 weeks, then you should be reassessing the patient, offering him maybe some sort of other treatment, and making sure that you're not that your initial diagnosis still stands, and that includes having some sort of imaging done on that patient. And then 12 weeks is sort of arbitrary, right? So we've decided on that. And, if, I would be concerned if I have patient coming into my clinic and, like, after 6 weeks of, good rehabilitation being offered to that patient, and there's no sort of improvement in terms of pain and disability. So I would be concerned about that. But if you see improvements, then that's fine. And some patients are not going to be cured after 12 weeks. But if they're doing better with what you're offering them initially, I think that's fine. But if within 12 weeks you're not seeing significant improvement of that patient, then you need to reassess that patient. And we know that some patients do have pain related to rotator cuff tendinopathy that, become very chronic and very disabled and so on and so on. But you need to make sure that you're not missing out on something if that patient's not improving. Yeah.
Yeah. And
After 12 weeks.
so I guess what we need to let people know is this is an open access from JOSPT, isn't it? That people
Yeah.
can look free of charge
Freely accessible.
Yeah, all 40 pages they can get right stuck into. But then in figure 2, which is just what you were referring to about the guideline, we also then haven't really talked about calcific tendinopathy and how the management of that might differ. Is there
Yeah.
or
So yeah. So if you look at the evidence there, because we're not requiring it, we don't think, if you look at the available evidence that initial imaging is necessary, then you're not going to be knowing if it's a calcified tendinopathy or not. So you're going to be treating that patient the same way as you would do either if it's calcified or not calcified. But
there's no other way to know. There's no other way that we could pull that out other than the imaging. Is that what you're saying?
Yeah.
Yeah.
Yeah. And then, this,
to be
Margie,
sure,
right?
Yeah.
To be sure. And this, right? Some calcification are not related to the patient pain, right? So we know that sometimes patient will, they're not painful, right? So if they're coming up with a calcified tendinopathy, and if, for example, they had imaging done in primary care and it shows that, your initial treatment shouldn't differ from the usual patient with non-calcific tendinopathy. It should be the same. If they're not doing well after 12 weeks, and then, it's a confirmed image calcific tendinopathy, then there are other options that you could be offering to this. And if you look at the some of the recommendations that we have to that, it could be calcific lavage. It's severe and it's painful and it's disabling. Extracorporeal shockwave therapy could be used too. So we've got grade C evidence for that. And actually also laser therapy, there's a bit of data out there actually, surprisingly showing that it could be useful for these patients. So 3 types of treatment. Some of them are more invasive, right? Obviously, calcific lavage. And in some cases, patient might not have access to the other types of treatment. So that might be the only thing to do. But we know that there's data showing that it's useful. How exactly it's working, that's another, I guess, another topic, because most of these calcific lavage do include injections of corticosteroids. So that might be the only reasons that they're, that these patients are getting better. It's not because we're pulling out the deposit, right? So yeah.
Okay, I think what a wonderful summary of all this enormous amount of work. In closing, what do you think is important for clinicians to take away? What's Jean-Sébastien, if you think the most important thing, if people, firstly, the first 3 pages of this document are a summary, aren't they? So
you have all the recommendations, all the 36 recommendations are within the first 3 pages. So if you have short period of time to look at the CPG, just look at the 3 first pages. But then you can, if you want a recommendation, you have more interest in, you can go see where the evidence are coming from. So the main message for me is, it's a good question. For me, I will go with the intervention part. For me, you have to start with education, make sure that the patient understand the patients understand what they have and what they can do to get better. So that's, for me, that's the most important thing. And then to have a good exercise program for them and make sure they understand why they do the exercises and how it would help them. So that's the main things for me. It's to start with a great education intervention, and then you move to the exercises. For the evaluation, it's just to make sure that you have excluded all the other possible shoulder diagnostic, and then you can be pretty sure that you have a rotator cuff tendinopathy. I don't use all the tests that are being presented in the CPG. I rarely do all these special orthopedic tests. Sometimes I do the painful arc, but it's mainly to see how the people the patient is moving. That's pretty the only reason I will do a painful arc of movement. But I do all these other tests to exclude all the other shoulder disorders. So that's my main message. And also, you have to make sure that you ask the good question for the psychosocial factor, the yellow flags. We haven't talked much about yellow flags, but it's very important to ask the right question, especially if you have some doubt that some yellow flag could explain the persistence of pain. Then you have to ask the right question and try to act on that if you are able, or to refer to the good person if they have to see like a psychologist or other health professional that could help them.
Because there was a really nice summary in that document around risk factors for not returning to work and risk factors for persistent pain, isn't there? So for people to just be across that, I guess, all those other factors that can influence people's pain.
Yeah, and there's so many.
Yeah, aren't there?
Unfortunately,
turns out humans are quite complex. So François, what do you think is the main message people should take from this?
I think if we keep talking about the initial assessment of patient, I think a lot, at least in Canada, and I think it's like that in New Zealand. We've briefly discussed that when we were there with you. But I think there are way too many patients getting imaging because they've got shoulder pain, and it's only rotator cuff tendinopathy. So we know from different studies that sometimes the results of an MRI or results of an ultrasound that's going to show just usual age-related changes in tendons are not related to necessarily the level of pain and the disability that the patient have, and it can actually cause deleterious effect in terms of increasing catastrophization and also kinesiophobia and so on and so on. And we know that some of these inappropriate imaging might actually worsen the outcomes of patient without any significant findings from these imaging. So stop imaging a patient from the get-go. You're doing imaging if patients are not doing well, and because it's going to change the way that you're going to treat them. Otherwise, there's no reasons to do it in a classic case of rotator cuff tendinopathy. And one thing that we haven't talked about, and that's the other range of in terms of the patient journey, and it wasn't part specific to our CPG, but in previous iteration of our CPGs on shoulder rotator cuff related stuff, we actually looked at surgery. And one thing, that one of the take-home message, if you're sending on these patients to be seen by MSK specialists or orthopedic surgeon, for example, today in 2025, acromioplasty, subacromial decompression is not recommended anymore to treat rotator cuff tendinopathy. So these patients shouldn't be brought on into the operating room to treat that. And it should be clear in the patient journey, that they'll probably never be surgical candidates because they've got a rotator cuff tendinopathy. We shouldn't be doing that. There are other stuff that we can do because they've got chronic pain and disability, but surgery is not one of them anymore. So,
which is a really nice take home and a really nice reminder for people, isn't it?
Yeah. Sure. Yeah.
Hey, well, I just wanted to thank you both for your time today. It's wonderful to catch up as always, and then wish you both a very Merry Christmas and all our listeners as well. It's been a busy year for 2025. You like in New Zealand, you would have like a New Year's resolution for 2026? Francois, you're sitting there in front of me. You have a plan? 2026 will be more of what?
2026 or personally or just professionally or
whatever fills your boots. I'm interested to
Wait,
hear.
I'll go with the usual stuff about our professions.
Okay. That doesn't sound as interesting.
No, it is. And then I can talk about some stuff. I think we need to in 2026. Let's cut the overdiagnosis and overtreatment if we can do that. So that's one thing as a profession. So I think it's sort of getting through our profession that we sort of need to be more cautious about over-diagnosing and treating our patient. And
Yes.
in terms of my life, well, what about trying not to overwork myself and try to take more time to relax and maybe travel a bit more. So yeah, for
Yeah.
sure.
Yeah, what about that? And for you, Jean-Sebastien, professionally for 2026,
Professionally,
what?
I hope we will
Yeah.
get this funding for the
Oh,
shoulder
me too.
dislocation project. So
Me
that's
too. I didn't
Yeah.
want
what
to
I
talk
hope.
about. I'm very excited about that. And we can maybe talk about that off here. So yes, there's
Yeah,
such a lot of space to work on.
yeah.
I'm trying not to talk about instability again in this podcast. But yeah, we are planning then a 10-year follow-up. So but and
Yeah,
yes, professionally, wouldn't it be nice to learn more about instability? And
yeah.
personally,
Personally, I hope to be able to travel a bit more this year, have time to train, and enjoy life,
yeah.
see friends, and
Yeah.
go for a drink more
Yeah,
often.
wonderful, wonderful. Hey, well, so nice to connect with you. Thank you.
Thank you for having us, and Merry
Thanks,
Christmas.
Marty.
Merry
Merry
Christmas.
Christmas to
Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.